We're going to continue now our discussion of gross anatomy by taking a look at the lower limb. Now, just as in the upper limb, the most important thing for us to pay attention to will be the neuromuscular components of the lower limb, the nerves and which muscles they innervate. And this is going to be, in many ways, much simpler than the upper limb because in the upper limb we have multiple exceptions that we needed to pay attention to. In the lower limb, there are no important exceptions. So this will go much more quickly. We'll take a very quick look at arterial supply to the lower limb and then look at a few of the skeletal injuries that are clinically important at the levels of the hip, the knee, and the ankle. So starting with the nerve supply, again, we'll have a nerve plexus providing the nerve supply just as we did in the upper limb. This will be the lumbosacral plexus. Again, these segmental levels indicated here represent the anterior rami of the spinal nerves, not the spinal nerves themselves. Again, only anterior rami go into the limb. In contrast to the brachial plexus, the lumbosacral plexus is much simpler because there are no trunks and there are no cords. We just have anterior and posterior divisions that form nerves. So we see that L2 has a posterior and an anterior division, L3 does, L4 does, and right on down the line. And then those divisions will come together to form nerves. So, for example, we see that the posterior divisions of L2 and L3 and L4 forms the femoral nerve. The anterior division of L2 and L3 and L4 forms the obturator nerve. And so on down the line. We have the posterior divisions of L4 and L5 and S1 and S2 coming together to form the common fibular nerve. And we have the anterior divisions of L4 and L5 and S1 and S2 and S3 coming together to form the tibial nerve. An important point to be made is that the separation into these anterior and posterior divisions that we see here is for exactly the same reason that we saw it in the brachial plexus. Because when the limb bud forms, the muscles that are going to be forming muscles, the cells that are going to be forming muscles are distributed within that limb bud in either the anterior or posterior side of the limb. And the motor nerves growing into the limb bud, therefore, either have to go to the anterior side or to the posterior side to innervate them. So we see that these nerves, for example, these posterior division nerves, must have been nerve fibers that grew to the posterior side of the embryonic limb. And these nerve fibers that are in anterior divisions must have gone to anterior side of the embryonic limb, just as we talked about before. But there's one important difference for the lower limb. We know that when we look at the adult lower limb, the femoral nerve, which is made up of posterior division nerves, does not innervate muscles in the posterior compartment. It, in fact, innervates muscles in the anterior compartment. So how can that be? And the reason for that is that after the lower limb bud starts to develop, and after the muscle compartments are formed, and after the nerve fibers grow into those muscle compartments to innervate those muscles, then the limb rotates. And it rotates almost 180 degrees internally so that what was anterior becomes posterior, what was posterior becomes anterior. But because the muscles are already innervated, we now end up with these muscles that were in the posterior compartment of the embryonic limb and therefore innervated by posterior divisions, now on the anterior side of the adult limb. And so that explains why we see anterior division fibers innervating posterior compartment muscles and posterior division fibers innervating anterior compartment muscles. It's because the limb rotates after the muscles are already innervated. A few other points to be made on this slide. We can see that in addition to the four major terminal nerves, femoral, obturator, common fibular, and tibial nerve, we see a couple of collateral nerves shown here, superior gluteal and inferior gluteal nerve. We have collateral nerves in the lumbosacral plexus for the same reason that we have collateral nerves in the brachial plexus, that is, to innervate the very proximal muscles. In the upper limb, the collateral nerves innervated the muscles around the shoulder and axilla. In the lower limb, the collateral nerves innervate the muscles around the hip and in the gluteal region. So these gluteal nerves are going to be innervating muscles in the gluteal region. In the upper limb, we had 5 terminal nerves. In the lower limb, we initially have 4 terminal nerves: femoral, obturator, common fibula, and tibial. But the common fibula will divide further distally in the limb into a superficial and deep fibula, so we indeed will end up with 5 terminal nerves, just as we had in the upper limb. And one last point to be made is, as illustrated here, the common fibular nerve and the tibial nerve run through a significant portion of the limb, usually through the gluteal region and the thigh, wrapped together in a common connective tissue sheath. And that structure that's held together by that connective tissue sheath is referred to as the sciatic nerve. So what that means is that the sciatic nerve is not really a nerve itself. The sciatic nerve is really a bundling together of 2 entirely separate nerves, common fibula and tibial. They are quite different from one another. Common fibula is a posterior division nerve. The tibial nerve is an anterior division nerve, so there is no exchanging of fibers within the sciatic nerve. And once we get down to about the level of the knee, those nerves will separate from one another and go their separate way. So it's only for the region of the gluteal region and the thigh, where they run together in a common connective tissue sheath, that they're given the name sciatic nerve. The distribution of these nerves, again, is pretty much a nerve taking care of all the muscles in a compartment. So, for example, the femoral nerve, which is a posterior division nerve, innervates all of the anterior muscles of the thigh. Again, because of that limb rotation, posterior nerve, anterior compartment. Since the muscles of the anterior compartment are all knee extensors, therefore the major function of the femoral nerve is to cause extension of the knee. The obturator nerve takes care of all of the muscles of the medial compartment. The medial compartment is primarily responsible for adduction of the thigh at the hip, so that's what the obturator nerve's major function is. The tibial nerve is an anterior division nerve, and because of the limb rotation, you'd expect it to innervate posterior compartment muscles, and indeed it innervates all of the posterior compartment of the entire lower limb. The posterior muscles of the thigh, the posterior muscles of the leg, and the plantar muscles of the foot, which are analogous to being posterior muscles of the foot. So really the entire posterior side of the limb is innervated by that one anterior division nerve. The posterior compartment of the thigh is responsible for flexing the knee and flexing the leg at the knee and extending the thigh at the hip. The posterior compartment of the leg is responsible for plantar flexion of the foot at the ankle and flexion of the digits. And the plantar muscles of the foot are also responsible for flexion of the digits. So those are the functions associated with the tibial nerve. The common fibular nerve, I said, is going to divide into superficial and deep branches. Before it divides, it innervates one muscle in the posterior thigh, but that's not an important thing to worry about. The 2 branches of the common fibular nerve each goes to a separate compartment. The superficial fibular nerve goes to the lateral compartment of the leg, and the function of those muscles is to evert the foot at the ankle. And the deep fibular nerve goes to the anterior compartment of the leg, and the function of those muscles is to dorsiflex the foot at the ankle and to extend the digits. So that really is pretty simple. It's a nerve doing a compartment, the compartment being responsible for one or more functions, and that's really all there is to it. We said that there are some collateral nerves. In the upper limb, we pretty much gave it short shrift. We said that there's not a lot that we needed to know about those collateral nerves. In the lower limb, however, although that's true for most of the collateral nerves, the first 2 collateral nerves listed here, superior gluteal nerve and inferior gluteal nerve, are important clinically, so we'll spend a few moments on each of those. However, the other nerves shown on this chart, as well as the remainder of the chart seen on this next slide, are really not important for us to be worrying about, so we will not spend any time on them. But let me come back to this chart, and we'll now go over the superior gluteal nerve and the inferior gluteal nerve one at a time. The superior gluteal nerve is an important nerve because it innervates two really important muscles. Now, there are three muscles that are listed here as being innervated by the superior gluteal nerve: gluteus medius, gluteus minimus, and tensor fasciae lati. That's true, but the tensor fasciae lati is not a muscle that can be clinically isolated and tested. So that's not an important muscle in terms of clinical manifestations of a superior gluteal nerve injury. The gluteus medius minimus, on the other hand, are important and can be tested, but in reality should be considered one muscle, not two, because they function together, they're innervated together. So either they will work or they won't work as a single muscle. Now, the function of that muscle is to abduct the hip. That's what it says here, abduct the hip, and then it says stabilize the pelvis, and we need to understand what that means. And in order to understand how the gluteus medius minimus works, and therefore why the superior gluteal nerve is important, we need to understand the general principle of how lower limb muscles are generally used. The overarching function of the lower limb is to support you and to prevent gravity from pulling you down to the ground. Gravity wants you to fall, your lower limbs want to hold you up. And so the major function of the lower limb muscles is to resist the force of gravity. So in contrast to upper limb muscles, where their major function is to cause movement, lower limb muscles, in large measure, have as their major function to prevent movement that gravity is trying to cause. So if you think of it that way, that means that the function of a muscle is not so much to cause the movement that is described as the function of the muscle, like, for example, the superior gluteal nerve innervates medius minimus, which abduct the hip. Well, in most cases, the use of the gluteus medius and minimus is not to abduct the hip, but rather to prevent gravity from doing the opposite, which is to adduct the hip. So these muscles, which are hip abductors, are largely used to prevent hip adduction. So when is gravity trying to adduct the hip? Well, gravity is trying to adduct the hip when the contralateral foot is not supporting the contralateral side of the pelvis. So, for example, when I am standing on my right foot with my left foot off the ground, gravity is trying to cause the left side of my pelvis to drop to the ground because my left lower limb is no longer supporting it. In order for the left side of my pelvis to drop toward the ground under gravitational force, there has to be an adduction of my right hip. My pelvis would move, my femur would stay still. That would be adduction of the hip. So if I can use a muscle to prevent adduction of my right hip, I'll prevent the left side of my pelvis from dropping. Well, the muscle that will prevent adduction of my right hip is the muscle that is designed to cause abduction of my right hip, which is my right gluteus medius and minimus. So when I am standing on my right foot with my left foot off the ground, my right gluteus medius and minimus are contracting, not to cause movement, not to abduct the hip, but rather to prevent movement, to prevent adduction of the hip, which is what gravity is trying to do by dropping the contralateral side of my pelvis. So that's what we mean by stabilizing the pelvis. The reason that's so important is when you think about the use of the lower limbs in ambulation, in gait, what walking fundamentally is an alternating standing on one foot and then standing on the other foot. And each time we stand on one foot, the gluteus medius and minimus of that side has to contract, which means the superior gluteal nerve has to work. So when you want to test for the right superior gluteal nerve, you have the patient stand on the right lower limb, take his left foot off the ground, and you watch the pelvis. And a normal person will be able to maintain the pelvis in a perfectly horizontal position. In other words, stabilize the pelvis by contracting the right medius and minimus. So you're standing on the right foot, you're testing the right medius and minimus, so you're testing the right superior gluteal nerve. That's called the Trendelenburg test. So a positive Trendelenburg sign would, on the right side, would mean you're standing on the right foot, the left side of the pelvis drops toward the ground, unstabilizing the pelvis. That would mean you have a weakness of the right medius and minimus, indicating a lesion relating to the right superior gluteal nerve or to the spinal cord segments contributing to that nerve. So that's the superior gluteal nerve. The inferior gluteal nerve innervates only one muscle, and that's the gluteus maximus. And the gluteus maximus is an important muscle for hip extension. But again, thinking about how the lower limb works, you're not using the gluteus maximus very much to extend the freely moving lower limb, but rather you're using the gluteus maximus to lift the body against the force of gravity. So when you're going from the seated position to the standing position, what you're doing is you are extending the hip, lifting the body against gravity. You're lifting the weight of the body against gravity. And to do that, you need a strong muscle, which is what the gluteus maximus is. Or when you're climbing stairs, your hip is going from a flexed to an extended position as you climb each step, and in doing so, you are lifting your body against the force of gravity. So again, you have to think of these muscles as anti-gravity muscles. The gluteus maximus is important for standing from a chair or climbing steps. And so those are the kinds of problems the patient would have who has an injury to the inferior gluteal nerve. Okay, so when we finished talking about the collateral and terminal nerves in the upper limb, we then turned our attention to the segmental innervation to the upper limb. And we said that although that was a whole separate pattern of innervation to learn, we said it was very simple because there was a proximo-distal gradient that we could apply. Well, pretty much the same is true in the lower limb with one slight modification. Again, in the lower limb, the segmental innervation to the muscles of the lower limb has a proximo-distal gradient. Again, that means the more proximal muscles are innervated by higher segments, the more distal muscles are innervated by lower segments. The thing that's different for the lower limb is that there are actually two proximo-distal gradients, one for the anterior side of the limb and one for the posterior side of the limb. So a way to apply this gradient can be the following. If we take the muscles of the lower limb and group them according to which is the major joint that they cross, and then do it for both the anterior side of the limb and the posterior side of the limb, we would group the muscles in the following way. We'd have muscles on the anterior side of the limb, some of which have as their major function to cross the anterior hip, some cross the anterior side of the knee, and some cross the anterior side of the ankle as we go from proximal to distal. Obviously, those that cross the anterior hip are hip flexors. Those that cross the anterior knee are knee extensors. Those that cross the anterior ankle are ankle dorsiflexors. And then take those muscles grouped in that way and then apply the gradient. Start from L2. Remember, at least 2 segments per muscle. So the muscles that cross the anterior side of the hip are innervated by L2 and 3. Those that cross the anterior side of the knee are innervated by L3 and 4. And those that cross the anterior side of the ankle are L4 and 5. 2, 3, 3, 4, 4, 5, as you go from proximal to distal. Then we do it all over again on the posterior side of the limb, again grouping them by joint, so muscles that cross the posterior side of the hip, posterior side of the knee, and posterior side of the ankle. So this time, muscles that cross the posterior hip are going to be hip extensors, crossing the posterior side of the knee will be knee flexors, and crossing the posterior side of the ankle will be ankle plantar flexors. And we use a gradient. The gradient starts 2 levels lower than the anterior gradient. So the anterior gradient started at L2 and 3, so this posterior gradient starts at L4 and 5. So it's L4 and 5 for the ones crossing the back of the hip, L5 and S1 for those crossing the back of the knee, and S1 and S2 for those crossing the back of the ankle. So it's the same general concept of a proximo-distal gradient, but with this minor variation of having two gradients, one for the front and one for the back. But in reality, in common practice, these segmental innervations are really significantly more important than the segmental innervations in the upper limb because of the much greater frequency of segmental injuries at these lumbosacral levels. Remember that the lumbosacral levels are the regions where weight-bearing injuries relating to lumbar vertebrae and discs are very common. So segmental injuries relating to lumbar disc herniations are really quite common. And it's for that reason that knowing these segmental innervations are really important, because that's how you can isolate the level of the injury when you're dealing with a patient who has an apparent lumbar or lumbosacral level segmental injury. So, for example, if you do a patellar reflex, you're testing the muscles that cross the front of the knee, you're testing L3 and 4, primarily 3. When you want to test L4 and 5, you ask the patient to dorsiflex, that is, stand up on his heels. You're testing dorsiflexion, you're testing L4 and 5. If you wanted to test S1 and 2, you would have the patient stand up on the toes. That's plantar flexion. You're testing S1 and 2, and so on down the line.